Swayam Prabha. Digital India. Educated India.
Hello everyone, I am Dr. Vijeta Shanoy. I work as Assistant Professor in Department of Biochemistry, Kasturba Medical College, Manipal, Manipal Academy of Higher Education. In this, we are going to discuss Biochemistry of Atherosclerosis. The topic will be discussed under following headings: definition of atherosclerosis, predisposing causes for atherosclerosis, events in atherosclerosis, what are biochemical investigations we can do in atherosclerosis, and the treatment for atherosclerosis. Coming to the definition, sclerosis is a Greek word which means hardening. Atherosclerosis is a complex disease characterized by thickening or hardening of the arteries due to accumulation of lipids. The accumulated lipids in the walls of the blood vessel narrows the lumen of the affected vessels. This in turn impedes the blood flow, decreases the blood supply to the affected organs. Atherosclerosis is one of the main killer in the world. In India, 20% of the mortality is due to coronary artery disease. It is estimated that by the end of 2020, it is going to increase by 33%. The arteries that are involved in atherosclerosis are most commonly coronary arteries. If the coronary arteries are affected, it leads to coronary artery disease or ischemic heart disease. If there are involvement of cerebral arteries, it leads to cerebral thrombosis. Peripheral vascular disease occurs if there are atherosclerosis affecting the arteries which supply the blood flow to the lower limbs. So, what are the events in atherosclerosis? LDL is the main culprit in atherosclerosis. When the LDL reacts with the free radical, it forms oxidized LDL. These oxidized LDL are taken up by a non-regulated pathway by macrophage. The LDLs gets deposited in the macrophage and forms the foam cell and fatty streak. This in turn damages the endothelial cell. Also, there is more accumulation of LDL embedded macrophages, there is release of cytokines, release of many growth factors from platelets and macrophages, finally leading to platelet aggregation, smooth muscle proliferation. All these factors causes vasoconstriction and finally formation of atherosclerotic plaque. There are many risk factors for atherosclerosis. These risk factors are classified into modifiable risk factors and non-modifiable risk factor. As the name says, modifiable means it can be prevented. For example, smoking. If there is cessation of smoking, the risk of atherosclerosis can be modified. Other modifiable risk factors are high total cholesterol, high levels of LDL cholesterol, high triglycerides and high fat diet. Also, obesity, stress, diabetes mellitus, hypertension are also modifiable risk factor. If intervention is taken in such condition, the risk of developing atherosclerosis can be minimized. Coming to non-modifiable factor, these factors which cannot be modifiable. For example, age, family history of coronary artery disease, and coming to gender, males have more preponderance over atherosclerosis than the females. What are the predisposing causes for atherosclerosis? Diabetes mellitus, obesity, hypertension, stress, high consumption of saturated fatty acids, lack of physical exercise, hyperlipoproteinemias, nephrotic syndrome and hypothyroidism. Let's see what is the link between diabetes mellitus and atherosclerosis. In diabetes mellitus, there is lack of insulin. If insulin is not present, the enzyme hormone sensitive lipase gets activated. The action of hormone sensitive lipase is to break down triacylglycerol from the adipose tissue to free fatty acid. When there is more accumulation of free fatty acids, it undergoes beta oxidation, and the final product formed at the end of beta oxidation is acetyl-CoA. Since there is lack of oxaloacetate, the oxaloacetate cannot bind with acetyl-CoA to enter into TCA cycle. So, all these acetyl-CoA are channeled for cholesterol synthesis. Next, we will see what is the link between obesity and atherosclerosis. If the person is obese, even though there are insulin receptor, they become insensitive, leading to glucose intolerance, insulin resistance, and finally leading to dyslipidemia. The next is cigarette smoking and atherosclerosis. Cigarette smoking enhances the oxidation of LDL. LDL is called as a bad cholesterol. The oxidized LDL is the main culprit in atherosclerosis. It further reduces the HDL level. There is more and more aggregation and addition of platelets to the vascular system. Cigarette smoking contains nicotine. This nicotine increases the lipolysis. When there is more of lipolysis, acetyl-CoA is generated. This acetyl-CoA goes for cholesterol synthesis, finally leading to increased production of total cholesterol. The effect of cigarette smoking on atherosclerosis, it depends upon its dose, the age at which the cigarette smoking is started, and also the number of cigarette smoked per day. Finally, what is the link between long chain saturated fatty acids and atherosclerosis? Saturated fatty acids are more harmful compared to unsaturated fatty acids. The saturated fatty acids, they act as a pro-inflammatory response. They impede the growth and viability of endothelial cells. When the viability of endothelial cells are damaged, they have more harmful effect on the vascular system, finally leading to atherosclerotic plaque formation. Relationship between HDL and coronary artery disease. HDL stands for high density lipoprotein. HDL cholesterol is called as a good cholesterol. HDL cholesterol is increased in conditions such as estrogen, unsaturated fatty acid, there is more exercise and reduction in body weight. So, all these factors increases the HDL, which in turn reduces the risk of coronary artery disease. There is one more lipoprotein which is called as lipoprotein A. This lipoprotein A is identical in structure to LDL cholesterol. What is the difference between LDL cholesterol and lipoprotein A is there is an additional apoprotein, that is ApoA, in lipoprotein A. The mechanism of action of lipoprotein A is to inhibit fibrinolysis. Fibrinolysis means breakage of clot. So, the action of lipoprotein A is to inhibit the fibrinolysis. So, the clot breakdown is inhibited if there is more accumulation of lipoprotein A. So, there are many preventive measures for atherosclerosis. One is to avoid the smoking, exercise regularly and maintain the normal body weight. There are many dietary measures. We will go into detail of dietary measures. So, what are the dietary measures that are available to reduce the risk of atherosclerosis? The amount of total cholesterol in the diet should be less than 200 milligram per day, because total cholesterol also contributes to development of atherosclerosis. There should be adequate amount of intake of polyunsaturated fatty acid. Unsaturated fatty acids, they have double bond. Polyunsaturated fatty acid means they have more than 2 double bonds. There are omega 3 series of polyunsaturated fatty acid, as well as there are omega 6 type of polyunsaturated fatty acid. The omega 6 fatty acids are mainly seen in vegetable oils, whereas omega 3 fatty acids are seen in fish oil. The ratio of omega 6 to omega 3 fatty acid should be 4:1. In Indian diet, since we take vegetable oil, fish oil, the concentration of the ratio of omega 6 to omega 3 is 30:1, whereas sunflower oil contains omega 6 to omega 3 ratio as 160:1, whereas the saturated fatty acid, for example, if you take ghee or coconut oil, the omega 6 to omega 3 ratio is 3:1, which means the coconut oil has almost similar what is recommended for polyunsaturated fatty acid. That is why coconut oil is more appropriate than consuming the sunflower oil, but always we should know that moderation is the key. So, coconut oil should be taken in moderation, because if you consume more of ghee, more of butter, more of coconut oil, the total cholesterol level as well as total calorie will also increase, leading to atherosclerosis. We have to restrict saturated and trans fatty acid. The trans fatty acids, they have double bond in trans position. These trans fatty acids, they are formed when there is partial hydrogenation of food substances. When there is partial hydrogenation, it increases the half-life of the food. So, these trans fatty acids are mainly used in bakery product. So, we should restrict more consumption of bakery product to prevent atherosclerosis. In the diet, there should be adequate amount of fiber. Per day, 30 grams of fiber in the diet is recommended. Fiber decreases the absorption of cholesterol and helps in more excretion of cholesterol, thus prevents the development of atherosclerosis. Also, we have to restrict the consumption of refined carbohydrate and sucrose. Sucrose, when it undergoes metabolism, more and more amount of triacylglycerol are formed, which also gets accumulated in the adipose tissue, increases the development of atherosclerosis. The diet should contain sufficient amount of vitamin C, vitamin E and vitamin A in the form of beta carotene, because all these act as a antioxidant. We know that oxidized LDL is the main culprit in atherosclerosis. So, taking sufficient amount of antioxidant reduces the oxidation of LDL, thus prevents the atherosclerosis. What are the plant derived products which have cholesterol lowering action? There is a big list, but I have highlighted only the important ones. The plant derived fiber, I have already explained what is the action of fiber. Fiber reduces the absorption of cholesterol, thus lowers the blood cholesterol level. Next is legumes, it also reduces the cholesterol level. Spices, flavonoids and red wine, all these they act as natural antioxidant and prevent LDL oxidation. Finally, onion and garlic, which is most commonly used in the food substance, it also has cholesterol lowering action. So, till now we have discussed the definition, what are the risk factor, how we can prevent atherosclerosis. Next we will discuss what are the biochemical investigations are done in case of atherosclerosis. Commonly done biochemical investigation includes lipid profile. Under lipid profile we can measure total blood cholesterol level, total triglycerides, LDL cholesterol, HDL cholesterol and ratio of total cholesterol to HDL cholesterol. To measure lipid profile, we have to take fasting blood sample. This should be taken after 10 to 12 hours of fasting. Once the blood is collected, serum should be separated and it can be used for the measurement of lipid profile. So, in which all condition lipid profile should be done? We should do lipid profile if we are suspecting a case of cardiovascular disease or coronary artery disease and peripheral vascular disease. In all patients with diabetes mellitus, at least once in 6 months measuring lipid profile is accepted. Patients suffering from thyroid diseases, liver diseases and renal diseases, they should undergo lipid profile because in these conditions lipid metabolism is altered. Finally, all the people above 40 years of age should be checked lipid profile once in a year. Other than lipid profile, you can measure other things, for example, apolipoproteins. Apoprotein A1 is a measure of HDL cholesterol which is called as a good cholesterol, and ApoB is a measure of LDL cholesterol which is a bad cholesterol. The ratio of ApoB to ApoA1 should be 0.4. If the ratio increases to 1.4, the risk of developing cardiovascular disease also increases. Other than lipid and apoproteins, there are other biochemical tests. Homocysteine, if the level of homocysteine increase to more than 15 micromoles per liter, then chances of developing atherosclerosis is more. Increased high sensitive C reactive protein, it is a marker for inflammation. Lipoprotein A, if the level is more than 30 milligram per deciliter, the risk of developing atherosclerosis is increased to 3 times. If lipoprotein A along with LDL is also increased, then the chances of developing atherosclerosis increase to 6 times. Finally, coming to treatment aspect. Mainly hypolipidemic drugs are given as a treatment for atherosclerosis. Important one is HMG-CoA reductase inhibitors, they are commonly called as statins, bile acid binding resins, probucol, nicotinic acid and finally antioxidants. HMG-CoA reductase inhibitors are called as statins. When we should start these statins? It is used as a secondary prevention in patients with established cardiovascular disease. It can be started in patients those who have total cholesterol level more than 220 milligram per deciliter, LDL cholesterol level more than 160 milligram per deciliter and the ratio total cholesterol to HDL cholesterol level is more than 6. It can also be started in people who have family history of premature coronary vascular disease. Finally, in patients with diabetes mellitus along with complications like retinopathy, nephropathy, microalbuminuria and hypertension. Let us see what is the role of these statins. In a cholesterol pathway, cholesterol synthesis pathway, there is a step in which HMG-CoA can be converted to mevalonate. In this, the enzyme used is HMG-CoA reductase which depends upon NADPH. This is the rate limiting step in cholesterol synthesis. If we give statins are structurally similar, it is a competitive inhibitor of HMG-CoA reductase, thus prevents the conversion of HMG-CoA to mevalonate and finally inhibits the synthesis of cholesterol. Coming to bile acid binding resins, there are two bile acid binding resins, they are cholesteramine and cholestypol. The mechanism of action of these bile acid binding resins are that decreases the reabsorption of bile acids. So, when it decreases the reabsorption, the excess of cholesterol goes for formation of bile acid and when the cholesterol gets converted into bile acid, the level of cholesterol decreases. How probucol decreases the cholesterol level? Probucol, it increases the LDL metabolism and prevents the accumulation of LDL in the arterial wall, thus reduces the atherosclerosis formation. Also, it converts cholesterol into bile acid and reduces the total cholesterol level. Coming to the action of nicotinic acid and aspirin. Nicotinic acid, it prevents the lipolysis. So, when the lipolysis is prevented, there is no formation of free fatty acid. It cannot undergo beta oxidation to form acetyl-CoA, when acetyl-CoA is the primary substrate for cholesterol synthesis. Since there is no acetyl-CoA, the cholesterol synthesis is inhibited, decreases the cholesterol formation. Aspirin, it acts as an antiplatelet activity and prevents the thrombus formation. Finally, antioxidants. The naturally occurring antioxidants are vitamin E, vitamin C and beta carotene. These antioxidants, they bind to the free radical and decreases the free radical formation. When free radicals are not there, then LDL cannot get oxidized. Thus, it decreases the LDL oxidation, and LDL oxidation is a main culprit for atherosclerosis, thereby prevents the atherosclerosis formation. To recap what we have learned in today's class, we have defined what is atherosclerosis. The sclerosis means it is the hardening of the arteries. In sclerosis, there is accumulation of lipids mainly. There are many risk factors for atherosclerosis. Some are modifiable, some are non-modifiable risk factors. Also, there are many causes for atherosclerosis. Some diseases like diabetes mellitus, hypertension, obesity, hypothyroidism, hyperlipidemias and so on. There are many preventive measures. Important ones are dietary measures. We discussed about the use of natural antioxidants. Coming to important biochemical test, one is complete lipid profile as well as extended lipid profile, and there are some other risk factors in which you can measure biochemical tests such as homocysteine, lipoprotein A estimation. And finally, the treatment aspect, we spoke importantly about statins. I hope you liked the class. Thank you.